everyone, thank you for joining me for this webinar on the PROS concepts for peri-implant tissue stability. I want to thank the International Congress of Oral Implantologists for inviting me to provide this webinar, and I'm looking forward to sharing these concepts with you today. My name is Dr. Jonathan Misch. I am from Ann Arbor, Michigan, where I underwent my dental school training as well as my training for periodontics. I'm currently operating in private practice out of Pinckney, Michigan. I am a Dean's Faculty at the U of M Periodontal Clinic, and I am also the CEO of the Misch International Implant Institute. But today, what we're going to be focusing on with these PROS concepts, before we get into those, we need to talk about marginal bone loss and peri-implantitis. And in particular, what we need to discuss is where the line begins between marginal bone loss and peri-implantitis, because it's very important in our discussion and our understanding. So here we have an implant that you can see on the left side, an implant that's placed, a healing abutment is put on at the time of implant placement, and then a few months later when they come back for the restoration, we can already see that there's been about a ½ millimeter of bone loss on this implant. This is what we would call marginal bone loss. And there's a few factors of why this happens that we're really going to get into when we talk more about the PROS concepts. But this is very different and is in stark contrast to peri-implantitis. And this is where that line is. When you see this timeline, we have on the left side crown placement, or this could be also healing abutment placement. 12 months later, we can see that there's been a little bit of bone loss on this implant. Within this first 12 months, we associate this with a physiologic process. We call this marginal bone loss, physiologic remodeling, aseptic bone resorption. It's all synonyms for the same thing, non-disease related bone loss. So that's what's happened on this illustration in the middle. We have a little bit of bone loss at this time, and it's within the first 12 months after loading. Thereafter, let's say those bone levels remain stable. In that case, we have an implant that we consider to be in health. There is no change in bone levels, there's no inflammation here, so this is a healthy implant regardless of where those bone levels were at 12 months. Let's talk about another scenario. After 12 months, we have a little bit of bone loss. That bone loss remains stable, and we probe the implant and there's bleeding on probing. This we would refer to as mucositis. This is just inflammation of the soft tissue, similar to gingivitis. It's a reversible condition. We really just need to clean this implant and it should be resolved. But this can progress into peri-implantitis. The third scenario, we have progressive bone loss. We have more bone loss after that 12-month mark. And in this case, we may be dealing with peri-implantitis, but there's a couple questions we should ask ourselves before we go diagnosing peri-implantitis and either treating or referring it for treatment of peri-implantitis. The first thing we should ask is, do I have a diagnostic record of this implant? Because if I do, I can look back at the x-ray from around 12 months and I can compare it to the bone levels today. If there's been progression of that bone loss, and there's inflammation, so bleeding on probing or suppuration, then I can diagnose that there is peri-implantitis on this implant. If I don't have a radiographic record, then I need to consider the supracrestal tissue height or the biological width, whatever term you're using currently. So biological width, supracrestal tissue height, we allow for about 3 millimeters. So if we have more than 3 millimeters of bone loss and inflammation, BOP, suppuration, and I don't have any other records of this implant, likely I'm looking at an implant that I can now diagnose peri-implantitis for. And this is based on the World Workshop on Peri-Implantitis, Peri-Implant Diseases from 2017. So clinically, our definition for peri-implantitis should be progressive bone loss beyond physiologic remodeling with signs of inflammation. So outside of the clinic, our definition of peri-implantitis, according to the World Workshop, is a plaque-associated pathological condition occurring in the tissues around dental implants characterized by inflammation of the peri-implant mucosa and progressive loss of supporting bone. And really what I want to highlight here is that this is a plaque-associated condition. And when you look at an implant surface like this, I don't know about you, maybe it's just because I'm a periodontist and I'm obsessed with bacteria, but I look at this implant surface and I just see millions of tiny micro surface structures that are perfect for bacteria to adhere to colonize, and to be protected by. And it's true that when we look at the literature, as surface roughness increases on implants, so does plaque retention on that surface. And even more than that, if you have ever looked at scanning electron microscopic images of different surface treatments on implants, it's really surprising the first time you look at it. These implant surfaces are very different from each other. So when we look at these three surfaces, we have hydroxyapatite blasted, anodized, and sandblasted acid etched implants. And you can see just from looking at this image, all three of them are very, very unique to each other. And theoretically, this should impact the way that the environment behaves as well. And in this study, what they did, they took these three implant surfaces, they took implants that were impacted by peri-implantitis and that had been removed due to severe peri-implantitis. They'd been explanted. And they treated these implants with various surface decontamination strategies to see if implant surface characteristics would impact our ability to clean the surface of the implant. And what they found was, as you might assume just from looking at those surfaces, very significantly it impacted the ability to remove all that bacteria. And those anodized implants, you saw all those tiny little pits that were present on that implant. Each one of those was a niche for bacteria that was protective and that we could not remove the bacteria from that environment. In another study by a friend of mine who also graduated from the University of Michigan, I actually work now with him in private practice, Dr. Khaled Sinjab. This, honestly, I believe will be considered a landmark article. They looked at those three surface characteristics, again, anodized, hydroxyapatite blasted, and sandblasted acid etched implants. And they wanted to answer the question, does the implant surface contribute to the state of disease? So when that implant surface is exposed, is it causing progression or is it impacting the presence of disease on that implant? That was the question they were asking. And what they found was that the anodized and hydroxyapatite blasted implants were actually contributing to their state of disease. So they were actually microbial, their profiles, their microbial profile from health to disease was completely different. So once that implant surface got exposed, the microbes that were present completely changed. But in that sandblasted acid etched group, they did not see a shift from health to disease. We had the same profiles of bacteria present in health and disease, causing them to conclude that these sandblasted acid etched implants were not contributing to a state of disease or dysbiosis. And again, this is not the only clinical study that shows that different surface characteristics might be at a different risk. In this classic landmark study by Dirks, looking at the prevalence of peri-implantitis, they saw that sandblasted acid etched implants had the lowest amount of disease occurrence, whereas you see their anodized implants 4 times more disease, 5.6 times more with the remaining types that were in this study. So implant surface characteristics may be impacting the presence of disease on these implants actually. Now that is all preliminary evidence. It is not enough for us that we can say the type of implant surface is increasing the risk for disease yet. So in general, when we talk about marginal bone loss though, what we find is that more marginal bone loss and more exposure of that implant surface increases risk of disease development regardless of the implant surface. In this study by Wendell, they showed that after 12 months, implants with more than 0.5 millimeter of initial bone remodeling had almost 5.5 times more peri-implantitis. In a study by Galindo Moreno, saw that 96% of implants that had more than 2 millimeters at 18 months of bone loss had at least about 0.5 millimeter at 6 months of marginal bone loss. And finally, the study by Andrea Ravita, they saw that thread exposure, so when an implant thread is exposed after initial remodeling, 8 times greater risk for developing peri-implantitis, and every thread was worth a 4x on that likelihood of disease. So implant surface being exposed is increasing our risk for disease. So how can we reduce marginal bone loss and increase marginal bone levels to improve our health of our implants and the stability of our bone levels for long term? That's where this study came in. When I was researching during my residency for my thesis and for presentations that I was giving to the perio and pros departments on prosthetics impact on peri-implant remodeling, I came across this study. And more than the study and the conclusion of the study, this histological slide is very important to the story of the pros concepts. Because when I saw this image, it made it very clear to me that there is a recipe that you can follow to have very high bone levels. Because this study histologically shows in these images bone depositing on the platform, on the abutment of these implants. So bone levels above the platform deposited on the platform, on the abutment of these implants. And they did it over and over again. So there has to be a recipe that we can follow for very high marginal bone levels from the start after initial remodeling that we can maintain long term. And I felt very strongly that being that my thesis was on prosthetics and their impact on marginal bone loss and peri-implantitis, that I was in a good position to be able to find this recipe. So in paying tribute really to, this is me thinking, how can this be possible? What recipe can we come up with? So in paying tribute really to my program director, Dr. Hamley Wong, I wanted to come up with past principles for marginal bone stability. And the reason I wanted to come up with past principles, because he published an article that was a recipe for predictable bone regeneration in your guided bone regeneration cases. And they were the past principles. This is a recipe, an acronym that you can follow for success in growing bone. The first letter, P, stands for primary closure. We know that we need to have primary closure so that we have a protected environment for bone to heal and grow. We need that closure to also be passive in nature, which is why you see here for these posterior ridge augmentations, we do both buccal and lingual releases. So we have optimal release and tension-free closure for that primary closure. The A in PASS stands for angiogenesis. So this is why we do things like perforating the cortical plate during these GBRs. We're inducing regional acceleratory phenomena. So this is going to cause remodeling of the bone, bring osteoclast and osteoblast to the area, increase blood vessel formation and angiogenesis, hence the letter angiogenesis. So it's going to increase those factors, increase the likelihood of bone formation. The first S in PASS is for space maintenance. So that's why we're using these bone graft materials in this case to maintain the space. This is a 50-50 blend of autogenous and cortical allograft. And stability is the last S. So in this case, we're doing the sausage technique where we're using this membrane to really hug this graft material in place. And you can see I'm placing pressure with that probe, and this graft material is not moving. It's very stable. And if we follow this recipe, we should have regeneration and success in our GBR procedures. So that's what I wanted to come up with. I wanted to come up with a recipe, and I wanted to call it PASS. But Dr. Wong, being very wise, said better than PASS would be PROS. And that's where the PROS concepts were born. So now we're going to go through this acronym. And as you may already know, this is published in the International Journal of Oral Implantology, the ICOI, official journal of the ICOI. And feel free to look this up and read this on your own. But let's go through these PROS concepts. P is for platform switch. We're going to be very brief on this because I think most of us are aware of the benefits of platform switching at this point. But in case you don't know what platform switching is, it's when you have an abutment that's the diameter is more narrow than the platform of the implant. So the one on the right is a platform switched implant. And when we look at why platform switching is helpful, it's because we move this micro motion of that superstructure inward away from the crestal tissues. And the question has been asked, is it the micro gap or is it the micro movement that's causing the bone loss? And this is a really nice study that was done by Herman and colleagues that asked that question. They had implants that had micro gaps of 10, 50, and 100 microns, micro gaps. And they looked at these different implants, and in one group, they welded the superstructure in place so that there was no micro motion present on that superstructure. And in the other group, they did not weld it, so they were allowed to have micro motion. So in one group, there's only a micro gap with no micro movement. In the other group, we have that micro gap, but we have micro movement also. And they looked to see what was the difference in marginal bone loss in these two groups. Found that the micro gap group, only 1 millimeter of bone loss versus almost 2 millimeters in the micro movement group. And many studies have reiterated now that micro movement is to blame for this marginal bone loss. That's important to note for one of our future letters in the PROS concepts. That's why I went through that. But systematic reviews have time and time again shown platform switching reduces marginal bone loss, but it also increases slightly the tissue thickness at the platform of the implant. And we know, just looking at this cross-sectional study by Tavelli and colleagues, increased tissue thickness may prevent dehiscence. 2 millimeter facial thickness in implants with no dehiscence, 1.3 in tissues in implants with dehiscence. That's a 0.7 millimeter difference. When we're talking about a platform switch, where at the platform of the implant we have up to 1 millimeter of increased thickness, that is very significant. That's a very significant amount of tissue thickness at the platform of that implant, and maybe why we also see improved tissue levels on platform switched implants. So moving to the second letter, R. R is for restorative design. And we're going to spend a second on restorative design because this is a little bit of a meatier topic. Restorative design, though, really starts back with P.I. Brandemark. And as many of you are probably familiar by now with, Dr. Brandemark coined the term osseointegration. This is the direct connection of living bone with the surface of an implant subjected to a functional load. At this time, though, in the 1970s, restorative design was very much an afterthought. The goal was just to get these implants to integrate. Getting the design of the restoration afterwards, that was very much not the important step there. So in the 1980s, when my dad came around and started talking about the importance of the prosthesis and the design of the prosthesis, he really is the one that made us start to say we need to consider the prosthetic before we consider the implant placement. He's the one that presented implant protective occlusion, fixed prosthetic classifications, FP1, FP2, FP3, removable prosthetics, RP4 and RP5, but really got us starting to realize we need to think about the prosthetic before we think about the location of the implant. And on the bottom left here, you can see some people are still placing implants based on the 1970s concept that bone availability is where the implant should go. That is not how we should be placing our implants. We need to consider the restoration and place the implant according to that restoration. It really, though, and from then, it's not until about 2010 that we start to really focus on this superstructure, the designs of these subgingival profiles and their impact on bone levels that we start to focus on. And in 2010, we see Sue publishing the critical and subcritical contour being that 1 millimeter below the free mucosal margin. That's going to establish where that free mucosal margin lies. Subcritical contour, everything below that. And the subcritical contour is where the literature has really focused the last 10 years. And that's what we're going to jump into really for the PROS concept. It's very important. The study by Katafuchi, very much a landmark article, looked at emergence angles and saw that if the emergence angle is greater than 30 degrees off that platform, we see 2 times greater risk of peri-implantitis. But what he also noted was that tissue-level implants are not sharing that same correlation with increased marginal bone loss and peri-implantitis associated with increased emergence angles. Another study by Yi and colleagues also saw increased marginal bone loss and peri-implantitis with emergence angles greater than 30 degrees, but also tissue-level implants were not sharing this correlation. And when we consider that an abutment has similar benefits as a transmucosal portion of a tissue-level implant in that it's separating the emergence from the tissues, it would make sense that a longer abutment may protect against disease and bone loss on our implants that have excessive emergence angles. So that's really the premise behind a study that we recently published in Clinical Oral Implants Research. This is the first study looking at the combined effect of abutment height and emergence angle. And it's the largest study that's ever been done looking at this. Actually, it's about 200 implants that were included. And in this study, what we did, we took 4 groups that had different emergence angle and abutment lengths: long, narrow, long, wide, short, narrow, short, wide. These were our 4 groups. And we wanted to see how was the bone levels on these different groups, how did these groups impact marginal bone level, and how did they impact disease. And what we saw was that on average, when we looked at the averages, the implants that had greater than 30 or less than 30 degree emergence angles, if the abutment was longer than 2 millimeters, there was no difference in the amount of marginal bone loss that was experienced, which is very much different than what the study by Yi showed, that more than 30 degrees in general should have more marginal bone loss. So here we see abutment longer than 2 millimeters is protective against marginal bone loss. We also saw that really supporting all the previous research that's out there, shorter abutments had more marginal bone loss than longer abutments. And finally, emergence angle only played a role when the abutment was less than 2 millimeters. So when the abutment was less than 2, short narrow had less marginal bone loss than short wide. But when the abutment was longer than 2 millimeters, long narrow had the same amount of marginal bone loss as long wide. In another set of data, what we looked at was the range of marginal bone loss. And this is really more important in my opinion. So we looked at less than half a millimeter, 0.5 to 1, 1 to 2, 2 to 3, or more than 3 millimeters of marginal bone loss. And we looked at the rates of those ranges of marginal bone loss in each group. And what we found was that very significantly, longer abutments had a less likelihood of having an increased range of marginal bone loss, but also that short wide group was very much at a higher risk of more severe marginal bone loss on those implants. And that's important for 2 reasons. One, it just shows us kind of the different ranges that we can experience. It shows us that we're being more protective of our implants if we have a longer abutment. But even more so for me, this is a reminder that in clinic, biology is not going to respond with a 100% rate of anything, right? So when you see here in that short wide group, 50% of these implants had less than half a millimeter of bone loss. It's not a 100% thing. So when you see things in your clinic, when you see a short wide group implant radiograph and there's no bone loss, that doesn't mean that this study is wrong. It very likely means that that implant is falling into these groups accurately. So just bear that in mind. When we looked at peri-implantitis, what we wanted to see really was that longer abutment protective against disease in the 30-degree groups, in the greater than 30-degree groups. And we did see 4 times more peri-implantitis in that short wide group. So yes, a longer abutment separating those emergence from the crestal tissues was very much protective. And this all supports what's called the aesthetic biological contour concepts. This was published by Ramon Gomez-Meda, Jonathan Esquivel, and Marcus Blatz back in 2023. And really, this is the updated critical and subcritical contour concepts. And if you're not familiar with this, you really need to be. This is how we should be designing our restorations for optimal stability of marginal bone levels. And what these stand for are the crestal, bounded, and aesthetic zones. Aesthetic zone is the same as that critical zone, that 1 millimeter from the free mucosal margin, and this is going to shape that free mucosal margin. The crestal zone is that initial 1 to 1.5 millimeters off the platform of the implant that we need to maintain a straight or concave profile to avoid invading the space for the crestal tissues. And the bounded zone, it's bounded between the aesthetic and the crestal zone. This is really, it should be looked at as space for connective tissue. So it should be concave, ideally. It can be straight, especially in thick phenotypes, but ideally we'd have a concave bounded zone. And here, you can see here, this, looking at etiological factors of disease, here when we have a tie base abutment, You can see how aggressive sometimes that emergence is off the platform just because of the flare of that tie base. And here we have a short, this would be classified as a short wide group. And we can see that exaggerated bone loss on that right side of the implant, excuse me, very likely because this restoration and this abutment is invading the space for the crestal tissues. And also what you can see here is just like that figure showed, not 100% of these implants with short, wide emergence and abutment heights are affected by severe bone loss. Some of them are stable, some of them higher likelihood of severe bone loss. How could this have been improved? Longer abutment would have been great. Customized abutment would have been great, but one of those two plans would have been much better than invading those crestal tissues. So that's the R in pros concepts. Now on to the O. O is for optimal connection. And when we talk about connections, we know we have internal and external. Very much accepted today, internal connections are much more stable. If you're not familiar with that, you can just do a literature dive, and time again, you're going to see external hex implants have much more crestal bone remodeling and also just undergo much more micro movement of that superstructure. But really, when we look at internal connection, we need to separate between conical connection implants and flat-to-flat interfaces, which would be considered internal hex. Conical connection implants have been shown to be much more stable. And when we look at systematic reviews and meta-analyses, let me first say actually, micromovement is actually built into the design of an internal hex implant. And if you think about this, the more intimate the fit for an internal hex implant, the harder it's going to be for you to seat that abutment. So they actually have to have a little bit of wiggle room there so that you can seat that abutment. So this micro motion is actually built into the design of the implant. Whereas conical connection implants can be very intimate to the point that they can even display cold welding so that they are so intimately fit that that abutment can sometimes fuse into the implant, and they have to have instruments for you to actually break the cold weld and remove the abutment sometimes. So they're very, very stable. If you're curious, do I have an internal, what is my internal connection? Just look at the internal surface of your implant. On the left, you'll see that hex. This is an internal hex. Even though there's that little taper off the platform, that doesn't make it conical. It's still an internal hex implant, and it behaves very, very differently under dynamic loads especially. Systematic reviews and meta-analyses time and time again, less marginal bone loss. This one in particular by Kampfons showed better survival rates in conical connection implants, better marginal bone levels, and fewer prosthetic complications. That, again, fewer prosthetic complications is shown time and time again because you have better load distribution, fewer and less force distribution, less force that's removing preload and causing a loss of things like abutment screw loosening, things like that. So conical connection implants, better marginal bone levels, and fewer prosthetic complications. But it depends on a few things. It depends on the cone angle, the angle of that conical connection. It depends on the depth of that conical connection. A deeper conical connection, so one that's called a deep conical, would be much more stable. Binding screw, it depends on the binding screw, and it depends on the manufacturer tolerance. And when you look at these different implant manufacturers and compare the degree rotation, degree canting, vertical discrepancy, you can see here, I'm not here to advertise for one implant company, so I replaced the implant company names with just 1, 2, 3, 4, 5, 6. But you can see implant 1 here is scoring better on almost every single one of these measurements. So there's very much a ideal connection out there that we should be looking for in our conical connection implants. This study by Ziprick, you can look at this up on YouTube, which is a really nice breakdown of what we're talking about here. But you can see when we subject this implant to a dynamic load with a conical connection, we don't have that micro motion of the superstructure. There's no micro gap formation. There's no micro motion that's moving to a greater degree than the implant body. And this is why we're having less marginal bone loss on these implants. That's one of the reasons. They also took an internal flat-to-flat implant with platform matching and put it underneath a resin that was similar to soft tissue, like gum tissue. And they put fluid on it, and they wanted to see, is this connection pulling fluid into the connection when it's subjected to a dynamic load. And you can see that fluid squishing into the connection. This is why when you remove an internal hex implant after about 5 years, this is why you have that stench that comes out of the patient's mouth after you remove that abutment, because fluids are actually being housed inside of that connection and bacteria are proliferating inside of that connection. That doesn't happen with conical connection implants because that seal is maintained throughout the life of the implant and the abutment connection. So moving from O to S, our final letter here on the pros concepts is subcrestal placement. Subcrestal placement has been shown, especially with platform switched implants and especially with platform switched conical connection implants, to be the ideal placement level for our implant platforms. You look at these studies by Sikera and DeGidi, showing very much that there's higher marginal bone levels on subcrestally placed implants. But it depends on a few things. It depends on the collar. So tissue level implants should not be placed subcrestally. You can see here the rough to smooth junction on a tissue level implant should be placed equicrestally, and this is supported by systematic reviews by Dr. Mohammed Saleh. Whereas bone level implants can be equicrestal or subcrestal, ideally slightly subcrestal. Another time that we might want to use a tissue level implant, though, is a case like this, where we're doing a very large regeneration. We've got some vertical regeneration that we're attempting here. And after we are completed with our GBR, we still, you can see here, we're anticipating that we're going to have a slight vertical defect because there's so much going on with this defect. We got a 10 millimeter intrabony defect, a 10 millimeter extra bony defect. So we're compensating by allowing for a slight vertical defect after we regenerate this bone. So after bone regeneration is done, you can see that we placed a tissue level implant. And what that's going to do is it's going to reduce our crown height space from that level to that level, right? And crown height space, what that is when we have, is the measurement from the platform of the implant to the occlusal surface. So on a bone level implant, when we place the implant at bone level, the crown height space is from the bone level basically to the occlusal surface. Whereas when I have a tissue level implant, my platform level is brought up 2 to 3 millimeters, depending on the implant that we're using. So we're reducing our crown height space, and studies show, the study by Nissen showed that there's an increase in prosthetic complications after a crown height space of 15 millimeters or more. So reducing that crown height space can be very helpful. Another thing that we need to consider with subcrestal placement is the presence of a buccal plate, because we're placing this subcrestally based on our buccal or palatal bone, but usually based on our buccal bone. And when we have no buccal bone, we can't place it subcrestal with respect to our buccal bone. So here, we're planning our implant platform level based on the planned free mucosal margin, not based on where my buccal bone is. And in general, what we should be looking for is to place that platform about 4 millimeters from my planned free mucosal margin. That's going to allow for enough running room for a nice contour and a nice aesthetic profile to our restoration. Finally, it depends on the platform. Platform matching implants ideally would be placed equicrestal as long as the prosthetic allows for that, whereas platform switching implants ideally would be placed subcrestal, but even more ideal obviously would be with a conical connection. You can see here, I placed an implant for this patient. We placed an implant and did simultaneous bone grafting. You can see our bone regeneration there, our implants well under bone. I place a healing abutment and send it back to the referring doctor. This doctor wanted me to place an implant that has an internal hex. You can see here, though, that we do have a little bit of a vertical discrepancy, or a little bit of vertical bone loss in this site. It's not 15 millimeters, so it's not going to increase prosthetic complications, but it will increase the force and the likelihood that we have a minor amount of micromovement of that superstructure. And so what's going to happen there, we're going to notice, as you see here, a small amount of remodeling that is going to find the platform of the implant. Whereas with conical connection implants, we're much more likely to experience bone levels above the implant platform for the life of the implant, not just during that initial healing phase. And this is really shown in this randomized control trial by Stacky. What they did here, they followed the PROS concepts. They had platform switch conical connection implants placed with one abutment, one time concepts with long transmucosal abutments. And you can see here, they placed it either 1 or 2 millimeters subcrestal. But at implant placement on the left, to restoration in the middle, to 1 year later, the bone levels maintained above the platform of the implant throughout this study for a year and likely longer. And what they found when they looked at all these implants was that in the group, 95% of implants had bone levels above the platform. 95%. There was over 100 implants here. So 95% of those implants had bone levels above the platform. What they saw was in the 1 millimeter subcrestal group, there was, well, let's just say in all groups, in all implants, there was a 0.5 millimeter of crestal remodeling. That's not marginal bone loss. That's remodeling of the bone at the crest. There's a 0.5 millimeter of remodeling, and it did not reach the implant platforms. So in the 1 millimeter subcrestal group, there was still a 0.5 millimeter of supracrestal bone on those implants. And in the 2 millimeter subcrestal group, there was still 1.5 millimeters of supracrestal bone on those implants up on the abutment. So that's what happens when we follow PROS concepts. And yeah, just to summarize, PROS concepts: platform switch, restorative design, optimal connection, and subcrestal placement. And I recently had a case that I was recording for a webinar that I'm going to be doing, for another webinar that I'm doing, and was able to record a surgery that really shows what it means to follow PROS concepts from the beginning. And PROS concepts aren't something that I recommend following just with the final restoration. It should be followed from the time of the implant placement. So here we have this case that came in. You can see that we have a failing number 8 in this case that needs to be extracted. And I want to use PROS concepts. And for me, PROS concepts are more than just the restorative concepts, the implant design concepts, the surgical concepts. It's the idea of increasing stability and increasing tissue thickness and increasing health of tissues in the area. So platform switching, when you think of platform switching, I mentioned that increases tissue thickness at the platform level of the implant. Restorative design, I mentioned the aesthetic biological contour concepts. That bounded zone is space for connective tissue. So it's providing stability to the tissues by increasing thickness of those tissues, which provides more blood supply, which allows for more stability. Optimal connection, having a stable suprastructure, is going to increase the space for those tissues because tissues can deposit further on the platform. So again, increases tissue thickness and stability. And subcrestal placement is the ideal location to place these implants. Really, if you think about subcrestal placement, what we're doing is allowing bone-forming cells to be at a level higher than the platform of the implant. And where we have bone-forming cells and stability of a clot, we have the potential for bone regeneration and bone growth, just like the past principles shown by Dr. Hamli Wong. So here we're doing all things that we can do to increase stability. This patient had some ankylosis of the buccal plate, so we ended up actually opting for socket shielding in this case. There was a recession on this case, just a very small one, but it was enough that I just wanted to correct that mucosal margin. So we're doing margin reestablishment therapy, as discussed by Jonathan Esquivel, having an under-contoured transitional prosthesis where we can increase the mucosal margin by about 2 millimeters during this healing phase. We're coronally advancing our tissues with autogenous grafting. Then this is what we look like immediately post-op, and what we looked at like 2 weeks after healing. So this is in a great spot now where I can send this back to my restoring doctor. I'm actually going to do my tissue training here, tissue shaping. You can see marginal bone levels are at a great spot. We're going to be able to have this following aesthetic biological contour concepts. And from the beginning, we followed the PROS concepts. So we have an optimal likelihood of having stable marginal bone levels moving forward. So with that, I just want to conclude that limiting marginal bone loss may be protective against developing peri-implantitis. Prosthetic contours should be separated from the crestal tissues, and Pros concepts offer predictable guidelines for stable peri-implant tissues. And with that, I just want to say thank you very much for your attention. Thank you for joining me today for this webinar. If you have any questions, feel free to DM me or email me. My email is down there on the bottom left, as is my Instagram handle, Dr. J. Misch. And I'm happy to answer any questions that you have. And I thank you for your attention. And I also thank you, ICOI, for the opportunity to share the pros concepts with you.